Imagine trying to inject a perfectly measured drop of fluid into a target space that is only like 500 micrometers wide.
Right, which is basically microscopic.
Exactly. I mean, you are working with margins so incredibly thin that a fractional shift of your hand just means catastrophic failure.
And to make this engineering nightmare even more complex, you have to do it completely blind.
Which is wild. So, welcome to another deep dive. Today we are exploring this medical puzzle for those of you who love to know the actual unvarnished mechanics of how things work behind the scenes.
We've gathered a stack of medical sources for this one. Anatomical texts, urogynecology surveys, and some really advanced ultrasound protocols.
Yeah, and our mission today is to answer one highly specific, just absolutely fascinating question.
Right, the question of how a clinician actually verifies their position in an invisible landscape.
Yes, specifically when a clinician is injecting a filler bolus into the anterior vaginal wall, how do they prove, like, both in real time and after the procedure?
That it landed exactly in the sweet spot.
Right. The sweet spot known as Halban's fascia,
Right.
rather than accidentally depositing it too shallow, in the superficial mucosa or plunging too deep into the muscularis.
Okay, let's unpack this. Because before we can even talk about the verification tools, the physical and visual cues, we have to map out the microscopic geography of the target itself.
Which makes sense. You can't hit a target if you don't understand what it's made of.
Hmm.
So Halban's fascia, which I noticed some of these papers refer to as the vesicovaginal septum.
Yes, that's another term for it.
Right, so it's nestled right between the tridon of the bladder and the anterior vaginal wall.
Yeah, and the term fascia here can actually be a bit misleading.
Oh, really? How so?
Well, for anyone used to thinking of fascia as just, I don't know, a stiff, inert wrapping caper around our muscles, this is different. The anatomical sources specifically define Halban's fascia as a mesenchymal lamina.
Okay, mesenchymal lamina.
Right. Mesenchymal tissue derives from the embryonic mesoderm, meaning it is this dynamic, living scaffold.
Not just a piece of tape holding things together.
Exactly. It is a highly active fibroelastic sheet. It's woven together with collagen, elastic fibers, and smooth muscular fibers. It is literally designed to stretch, support, and adapt.
And it is heavily vascularized and innervated, right?
Really innervated, yes.
Because the notes constantly reference these structures called Krauss bodies being packed inside this lamina. I know they are pseudocorpuscular nerve endings, but what does pseudocorpuscular actually mean?
Yeah.
Like in terms of how this tissue functions?
Good question. So standard corpuscular nerve endings, like the Pacinian corpuscles.
The ones that detect deep pressure in your fingertip.
Exactly. Those are wrapped in a thick, very distinct multi-layered connective tissue capsule, like an onion.
Okay, got it.
And that capsule dictates exactly what kind of mechanical force the nerve responds to. But Krauss bodies are pseudocorpuscular because their capsule is thinner, sometimes it's even incomplete, or just less structured.
Oh, interesting. So they respond differently.
Yeah, this anatomical quirk makes them uniquely tuned to specific types of mechanical stretch and friction, rather than just blunt pressure.
So when this specific fibroelastic space is physically stimulated, those thinly encapsulated Krauss bodies just fire off rapid signals.
They do, and that triggers a localized autonomic loop. Because this space has such a rich blood supply, the stimulation of those Krauss bodies causes the local arteries to dilate and the venous outflow to restrict.
So the blood comes in but doesn't leave as fast.
Right. The tissue physically engorges with blood. This vasocongestion creates a very specific, pleasurable, erotic response.
Wow, okay.
And the entire physiological goal of injecting a filler, whether it's, cross-linked hyaluronic acid or autologous fat,
Is to physically project and support that highly sensitive lamina, right?
precisely. You are giving the Krauss bodies a firmer mechanical scaffold, which essentially lowers their threshold for activation.
But the margin for error here is brutal. I mean, if we think about this like a delicate, multi-layered pastry.
Oh, I like that.
Yeah, so you're the baker, and your goal is to inject the cream filling exactly into the middle layer.
Right.
But you have to do it without cracking the crust on top, which would be the mucosa, or punching through to the plate below, which is the muscularis.
That is a perfect analogy. Because if a clinician misses that 500 micrometer middle layer, the functional outcome of the procedure is completely nullified.
It just doesn't work.
It doesn't work, and it can cause problems. If the needle stays too shallow, infiltrating that crust, the mucosal epithelium, you miss the Krauss bodies entirely.
Right.
And more critically, the tissue up there is just too dense to accommodate the volume of the filler. You end up creating these superficial nodules, which are basically hard, uncomfortable lumps.
Yikes. And you also run the risk of the Tyndall effect, right?
Yes, exactly.
Which is a physics phenomenon, like Rayleigh scattering. The hyaluronic acid filler is sitting so close to the surface of the mucosa that it scatters incoming light, specifically the shorter blue wavelengths, making the tissue look bruised or just distinctly blue.
Yeah, it leaves a permanent bluish hue on the tissue until the filler either degrades naturally or is medically dissolved.
That sounds awful.
It's definitely not the goal. And then on the other end of the spectrum, if the clinician drives the needle too deep and punctures that bottom plate, the muscularis layer, the filler simply dissipates.
Because the muscle is moving too much?
Exactly. Muscle beds are highly dynamic, contractile environments. A filler bolus injected there will just disperse and migrate. It provides absolutely zero structural support to Halban's fascia. So hitting that exact middle lamina is non-negotiable.
Man. So this raises the core question of our deep dive. The clinician is working from the outside. They are navigating this delicate, microscopic pastry filling process completely blind.
Completely blind, yes.
The literature points to this intense reliance on tactile feedback, specifically a technique called loss of resistance. And I'm imagining that this has to do with the density of the different layers.
It relies entirely on the mechanical properties of the anatomy. Halban's fascia, that vesicovaginal septum, it acts as an avascular potential space.
A potential space, meaning it's not like an empty cave in there.
No, not an empty cavern at all. It is more like two wet panes of glass resting against each other.
Oh, okay.
They are touching, but they can be separated. So when a clinician advances the needle through that dense vaginal mucosa, there is significant physical pushback against the plunger of the syringe.
Because you're trying to force fluid into tightly packed epithelial cells.
Right. The pressure required is very high. But the moment the needle tip breaches that dense tissue and enters the potential space of the septum, the clinician begins to infuse fluid, usually a local anesthetic mixed with the filler or just the filler itself.
And that fluid acts as a wedge, right? Like hydrodissecting the tissue layers apart.
Exactly.
The pressure just drops. It's basic fluid dynamics. You go from a high-resistance environment to an environment that readily accepts the fluid, creating a little fluid bubble between those panes of glass.
And so the surgeon's hands are literally feeling for that sudden plunge and the required injection force. The tactile pop, or the sudden smoothness of the plunger, that is the primary navigational beacon.
Right.
It tells the clinician's neuromuscular system that they have breached the correct plane. But tactile arrival is only the first step.
Right, there's more to it.
Oh, yeah. Before a single drop of the actual filler bolus is deployed, the protocols mandate a sustained aspiration for a minimum of 10 seconds.
10 seconds of holding a needle perfectly still under vacuum inside highly sensitive tissue. I mean, that is a massive amount of time in the surgical setting.
It feels like an eternity.
My deduction here is that this has everything to do with the vascularity we talked about earlier.
You nailed it. Halban's fascia is heavily vascularized, and sitting just beneath the mucosa is this really complex submucosal vascular plexus. The clinician has to prove they haven't accidentally cannulated a vessel.
Because if they did, and they inject filler,
If the needle tip is resting inside an artery or a vein, injecting filler will cause an embolic event or severe tissue necrosis. You are physically blocking the blood supply to the vaginal wall.
oh man. So aspiration creates a negative pressure vacuum in the syringe. If the tip is in a vessel, blood is drawn up the needle into the hub, signaling the clinician to immediately abort and reposition.
Right.
But why does it take a full 10 seconds? Like, wouldn't you see blood instantly?
You'd think so, but it comes down to rheatology and the physics of the equipment. Blood is a viscous fluid, and a 23-gauge needle, which they use for this, is incredibly narrow. It provides massive resistance to flow.
Oh, I see.
So according to the principles of fluid dynamics, drawing a thick liquid through a narrow tube under a weak vacuum just takes time. Furthermore, the vessels in this plexus are small and the surrounding tissue is dense.
So it could, like, pinch the vessel.
Yes, the tissue can compress the vessel walls against the needle bevel, temporarily blocking the flow. If a clinician only aspirates for 2 or 3 seconds, the vacuum just hasn't had time to overcome that mechanical resistance.
And they get a false negative. They assume the needle is in the avascular space, and they inject filler straight into the bloodstream.
Exactly. It's a disaster.
Okay, so the tactile drop in pressure tells them they are in the potential space. The 10-second aspiration confirms they aren't inside blood vessel.
Right.
Then they begin to slowly deploy the filler bolus. But they still have to verify that the fluid bubble is expanding in the correct lamina and not just pushing upward into the shallow crust. And the sources describe this visual warning sign called blanching.
Right, so what's fascinating here is the physical mechanics of why blanching happens. Blanching is the immediate, stark whitening of the normally pink vaginal tissue. It is a critical visual alarm.
I'm trying to picture the hemodynamics of this. The tissue is pink because of the capillary beds perfusing the
Yeah.
mucosa, right? So if the tissue suddenly turns white while you are injecting, it means you've deposited the volume too superficially. The filler is expanding inside that tight mucosal layer, and the local hydrostatic pressure of the filler bubble is literally exceeding the mean arterial pressure of the tiny capillaries.
You've got it. The filler physically crushes the capillary beds, squeezing the blood out of the local tissue. You are watching local ischemia happen in real time.
That is terrifying. So if a clinician sees the tissue blanching, the instinct would be to yank the needle out immediately, right, before any more damage is done.
Instinct would suggest that, absolutely. But the FDA instructions for specific bulking agents like URYX explicitly forbid it.
Wait, really? Why?
The protocol dictates stopping the injection immediately, of course, but you have to hold the needle perfectly still, sometimes for a full 60 seconds.
Oh, because the tissue is highly pressurized. If you pull the needle out while the local pressure is that high, you just create a low-resistance escape route.
Exactly. The filler will track right back out of the injection tract and leak. You lose the product, and you lose control of the placement entirely.
Wow.
By holding the needle completely stationary, the clinician allows the local tissue pressure to equalize. It gives the filler material time to integrate and solidify slightly into this spongy mass.
And once the pressure gradient neutralizes,
Yeah,
the needle can be withdrawn safely without a blowout.
exactly.
It is staggering how much of this relies on the clinician being an absolute master of their own physical senses. Processing the microscopic drop-in resistance on a syringe plunger, managing the physics of a vacuum for 10 seconds, calculating tissue perfusion pressures by sight.
It requires immense skill.
But human senses, no matter how finely tuned, they have limits.
Yeah.
And we're talking about a 500 micrometer tolerance. At some point, you have to introduce mechanical limiters to augment the human hand, right?
You do. Tactile feedback is subjective, which is why specialized surgical tools are introduced to remove the guesswork of depth control. Clinicians frequently utilize specialized 23-gauge needles that are manufactured with built-in physical stoppers.
Okay, so instead of a smooth needle shaft where you have to visually guess how deep you've gone, the needle itself has a mechanical collar, or like a thickened ridge engineered at a very specific distance from the bevel.
Yes, a depth-limiting feature. When the clinician advances the needle, the stopper physically bottoms out against the superficial mucosa.
Oh, that makes sense.
It makes it mechanically impossible to plunge the needle too deeply and breach the muscularis or the bladder wall. It solves the problem of punching through the bottom of our pastry.
But a mechanical stopper only prevents you from going too deep. It doesn't actually verify that the filler spread perfectly into the mesenchymal lamina of Halban's fascia once it left the needle tip. To get the final, undeniable proof of placement, the sources turn to advanced imaging, specifically ultrasound.
Yes. TRIS, which is transrectal ultrasound, and TVUS, transvaginal ultrasound. These serve as the ultimate verifiers in this space. They bridge the gap between tactile feeling and objective visual proof.
I can see how TROS would be used during the actual injection because the ultrasound probe is positioned in the rectum. It leaves the vaginal canal completely unobstructed for the clinician to manipulate the syringe.
Right. TRUS provides real-time, live-action, cross-sectional mapping. The clinician basically watches the monitor as the needle glides through the anterior vaginal wall and into the vesicovaginal septum.
And they can visually confirm the trajectory avoids the bladder wall entirely.
Exactly. But the true gold standard for proving the exact lamina placement of the filler bolus happens after the needle is withdrawn, using endovaginal 3D ultrasound.
TVUS post-verification. But how clear is this imaging, really? Can it actually differentiate between a 500 micrometer mesenchymal lamina and the muscularis directly beneath it?
Oh, it's incredibly precise. High-resolution 3D endovaginal ultrasound relies on acoustic impedance. Different tissues bounce sound waves back at different intensities.
Okay.
So the dense collagen and elastin fibers of the areolar tissue in the vesicovaginal space, they are highly reflective, meaning they show up as hyperechoic on the monitor.
Hyperechoic, meaning bright white.
Bright white and distinct, yes, compared to the darker, less reflective muscle tissue below it.
So the ultrasound maps a clear topographical boundary.
It maps what clinicians call the four-layer block, the epithelium, the lamina propria, the muscularis, and the adventitia. The clinician scans the anterior wall and looks for the filler bolus. They can measure its exact volume, ensure it is nestled perfectly within that specific hyperechoic layer of Halban's fascia, and confirm it hasn't migrated laterally or, tracked upward toward the bladder neck.
This actually makes me wonder about the sequence of these tools.
Yeah.
I mean, if high-resolution 3D ultrasound can map these 4 layers so flawlessly and identify the exact micrometer depth of the filler, why go through the grueling process of tactile navigation?
That's a fair question.
Why rely on feeling a loss of resistance or staring intensely at the tissue for blanching? Why not just use the ultrasound as a video game screen the entire time and guide the needle perfectly by sight?
It's tempting to think that way, but because screens, no matter how advanced, have latency and artifacts. Sound waves can be distorted by air bubbles, fluid pockets, or even the acoustic shadowing of the needle itself.
Oh, right.
An ultrasound might render a dense fiber that mimics a needle tip, or a shadow that looks like a fluid pocket. Mechanical feedback, on the other hand, that loss of resistance, it transmits at the speed of human reflex. A highly trained clinician's neuromuscular system processes the tactile change in pressure instantly.
Ah, I see. Because if you wait for the monitor to show you that the tissue is blanching or that the fluid is pooling in the wrong layer, the physical damage is already done.
The error has already been committed, exactly. Real-time tactile and visual tissue feedback prevents the error from occurring in the first place. The ultrasound is not the driver. It is the final receipt of a job well done. It is the objective proof that the tactile navigation was successful.
So what does this all mean? We set out to answer how a clinician verifies they've hit a microscopic target deep inside human tissue. And the answer is this incredibly layered triad of verification.
It really is.
It begins with the fundamental biology, understanding that Halban's fascia isn't just an empty gap, but a dynamic mesenchymal lamina packed with Krauss bodies that will only respond if the filler bolus is perfectly placed.
Right.
Then it relies on mastering the physical physics of the injection, hydrodissecting the potential space to feel the pressure drop, holding a 10-second vacuum to outsmart the viscosity of blood, and watching the tissue perfusion to catch blanching before the pressure causes ischemia. And finally, it culminates in technological proof, using mechanical needle stoppers to restrict depth and high-resolution 3D ultrasound to verify the acoustic impedance of the 4-layer block.
Whether you are studying urogynecology, developing medical devices, or simply fascinated by human biomechanics, recognizing this interplay between human touch and high-tech imaging completely reframes how we view modern surgery. We are no longer just treating the body on a macro scale. We are navigating microscopic ecosystems with a profound respect for their individual layers.
It fundamentally shifts the paradigm. We are successfully augmenting invisible spaces measured in fractions of a millimeter using nothing but fluid dynamics, acoustic waves, and the incredible sensitivity of the human hand. Which leaves me with a lingering thought for you to explore on your own.
Oh, I'm ready.
If our ultrasound tech and needle mechanics can now safely navigate and structurally augment a 500 micrometer lamina hidden deep inside the pelvic floor, what other microscopic continents hidden inside the human body are we just beginning to map? And as our resolution gets sharper, how might treating those invisible spaces completely change our understanding of the human experience in the next decade? Something to mull over until next time. Thanks for joining us on this deep dive.